Hi, good evening, everyone. Is the volume okay? Can you hear me? Oh, perfect, perfect. Well, thank you so much for joining the exam review this evening. I'm glad to have you here. So, I have about 30 questions that I prepared, and basically, they're going to be questions that are very similar to the type of questions you can kind of expect to see on the exam. So, I thought we could kind of go through them, and maybe if you're comfortable, you could kind of type in your answers in the chat. And remember, this is not a time to be embarrassed if you get something wrong. You know how nursing exams are. They're always set up to be everything's right, but one thing's more right. So it's a great time to facilitate discussion on why one answer is correct. So, please don't be shy about shouting out your answers. Um, I hope everybody's been staying safe and warm today, and it looks like classes are canceled tomorrow as well. So, staying safe and warm for tomorrow. Let's go ahead and get started. Uh, see here. Okay, let's go to our first question. When assessing a woman at follow-up prenatal visits, the nurse would anticipate which procedure to be performed. Is it the hemoglobin and hematocrit, the urine for culture, a fetal ultrasound, or a fundal height measurement? Which one do you think that the nurse would anticipate performing at a follow-up prenatal appointment? Okay, Jessica says urine. Chloe says fundal height. Emma says fundal height. Okay, any more guesses? All right, well, let's look at the answer. And it is indeed fundal height measurement. So the answer for urine, we actually do a urine dip. So we do a urine analysis at every prenatal appointment. So you were really close, but this one specifically asked for urine culture. So the only time we would do a urine culture would be if we were concerned about a urinary tract infection that we got based on an analysis. So hemoglobin hematocrit, that's not necessarily routinely done at every visit. We know fetal ultrasound is usually just done at one time during the pregnancy, but fundal height measurement is always done between 16 weeks and 36 weeks. And again, the centimeter marking would be equivalent to what the gestational age should be. And if there were to be any discrepancies, then we would do another ultrasound to follow up. Any questions on that one? All right, let's move on. A pregnant woman in the 36 weeks of gestation reports that her feet are quite swollen at the end of the day. After careful assessment, the nurse determines that this is an expected finding at this stage of pregnancy. Which intervention is appropriate for the nurse to suggest? Would we tell her to limit her intake of fluids, eliminate salt from your diet, try elevating your legs when you sit, or wear spandex type full length pants? What would we say? Okay. Oh, a bunch of C's. Any others? And the C's are correct. Absolutely. So we know that edema is common in the lower extremities. That's kind of one of the common things that can happen during pregnancy. It doesn't happen to everybody, but happens to a lot of people. And so swelling in the lower extremities is best dealt with by just making sure that they sit down and elevate their legs during the day. And that should really help with that. Any questions about that one? Okay, you're doing great. Question 3. A nurse strongly encourages a pregnant woman to avoid eating swordfish and tilefish because these fish contain which component? Is it too much folic acid, which could increase the risk for neural tube defects? Is it mercury, which could harm the developing fetus if eaten in large amounts? Lactose, which leads to abdominal discomfort, gas, and diarrhea? Or low quality protein that just does not meet the woman's requirements? Yay! Oh, you guys make me so proud. So you're right. It's mercury. So deep sea fish, tilefish, swordfish, all those fish contain, because they're deep sea fish, contain pretty high levels of mercury. And of course, that can actually cause brain injury to an infant.
Hello.
Yeah, it works.
Okay. Professor Cook, you may be muted. Or I know someone in one of my other classes said that they had accidentally muted the professor, so I don't know how that
Hello?
happened, but I can hear you.
Can you hear me?
Um,
Yay! Okay. Yay! Sorry guys. I hope this is all okay. Um I got a little bit of a conversation of you two being the professor. I just wanted to let you know there has been an issue in the past with students sharing uh, intellectual property with what the professor creates to sites that allow students to upload these things, and in return they give them access to cheat sheets and so forth. And so it was a really big deal that we had to tell everybody that this, any work that we do create, a slideshow or presentation, I have to add that this is my intellectual property, so you are actually violating copyright laws if you do attempt to do that with any professor. So I just wanted y'all to be very aware of that. I actually had to report students that did this in the past when we discovered this, because they shared my information that I created for money in exchange, and that's just a no-go. So I just caught the tail end of that. That might not even be what you're talking about, but I'm going to let you know that if this is my intellectual property, you're violating copyright laws if you share anything that I share with you. Okay. On a good note. Okay, so mercury, yes. So mercury is a deep sea fish. So it can cause brain damage to infants. So things like salmon, tuna, shrimp, all of those are fine. Those are not considered deep sea fish. So just those deep sea fish, shark, tile fish, swordfish, those types of things. Any questions? Okay, let's go to question 4. Assessment of a pregnant woman reveals a pigmented line down the middle of her abdomen. The nurse documents this as which finding? Is it a linea nigra, striae gravidarum, melasma, vascular spiders? Woohoo! All right, absolutely. So remember that brown line? That's called the linea nigra. And so that often appears during pregnancy. Sometimes it kind of sticks around a little bit with darker skinned babies. And sometimes it can kind of come back when you're exposed to sunlight. But that is one of the things that can occur with pregnancy, as can the other three. But when we're specifically talking about that pigmented line down the middle of the abdomen, we are indeed talking about linea nigra. Any questions about this one? Okay. Question 5. A woman has just given birth to a healthy term newborn. Upon assessing the umbilical cord, the nurse would identify what findings as normal. So this is a select all that apply. So is it one vein, one artery, two arteries? What would we expect? Oh, Jaylene even used the Ava. Yeah, the Ava's a great memory aid. I always think of that name. So absolutely. So it's one vein and two arteries. Awesome. Any questions about that one? Okay. A woman is at 20 weeks gestation. The nurse would expect to find the fundus at which area? Would it be just above the symphysis pubis, midway between the pubis and the umbilicus, at the level of the umbilicus, or midway between the umbilicus and the xiphoid process? Where would we expect it? Look at you go. You're doing so great. So, yes, at the level of the umbilicus, which is equal to about 20 centimeters. So, generally, the umbilicus is going to be 20 centimeters from the symphysis pubis when they're pregnant. So, at 20 weeks, they should definitely be at the level of the umbilicus. Great job. Okay, let's go to the next one. Question 7. A nurse is auscultating the chest of a woman at 16 weeks gestation. The nurse notifies the healthcare provider about which finding. Is it heart rate 25 beats per minute above the baseline? Would it be clear breath sounds, symmetrical chest movement, or fundal height at 16 centimeters? Which one would we want to notify the healthcare provider about? All right. I see some A's, and you are indeed correct. So we know that with pregnancy, we get about 50% extra blood volume, 40 to 50% extra blood volume. And so that's going to increase the workload of the heart. And so we do expect that the pulse will increase anywhere from 15 to 20 beats per minute, but 25 beats per minute is beyond that range. And so that would be something we would probably report. We would love clear breath sounds. We'd love to see symmetrical chest movement. And if she's just 16 weeks gestation, then we wouldn't expect to find their fundal height at 16 centimeters. Good job. Okay, a nurse assessing the laboratory results of a pregnant woman in her second trimester notes that she had a hemoglobin level of 11 grams per deciliter. What will the nurse interpret this finding to most likely indicate? Would it be iron deficiency anemia, a multiple gestation pregnancy, a greater than expected weight gain, or hemodilution of pregnancy? I'm just like crazy proud of all of you right now. You are right. It's going to be hemodilution of pregnancy. So we know that a hemoglobin level of 11 is a normal finding in a pregnant woman. It could be considered anemic in a non-pregnant woman, but not a pregnant woman. So that's why it's not going to be iron deficiency anemia. It's just due to hemodilution of pregnancy. Great job. Okay, a woman is in her third stage of labor. Which finding would alert the nurse that the placenta is starting to separate? Is it the uterus becoming more globular? Would it be the fetal head at the vaginal opening? Would it be when the umbilical cord shortens or when the mucus plug is expelled? Okay. All right, we got some mixed answers here, so that's great. So, on the third stage of labor, remember that's when the placenta is separating. So, we see a couple signs that the placenta is separating. First of all, we usually get a little gush of blood. We'll usually see that the umbilical cord starts to lengthen because the placenta is starting to separate. And then the uterus will actually take on a globular appearance, kind of more roundish appearance because it's cramping down and pulling out that placenta. So the answer is A. So it wouldn't be the fetal head at the vaginal opening because that would probably be stage 2. We wouldn't have a baby after the placenta is delivering. We would expect the umbilical cord to lengthen. And of course, the mucus plug better be gone by this point if we're delivering the placenta. So that is the answer. Any questions about that one? Okay. Question 10. A woman has not received any medication during labor, and she's having frequent contractions every 1 to 2 minutes and has become irritable with her coach and no longer will allow the nurse to palpate her fundus during contractions. Her cervix is 8 centimeters dilated. The nurse interprets these findings as A, the second stage of labor, B, the latent phase of the first stage of labor, C, the transition phase of the first stage of labor, or D, the active phase of the first stage of labor? All right, good job, everyone. I see C, and that is correct. So again, the transition phase of labor is the shortest phase. It's generally when they're about 8 to 10 centimeters dilated. This usually when they're the most miserable at this point. Again, they sometimes get like a sweaty upper lip. They sometimes get nausea and vomiting. They usually will have a lot of complaint of rectal pain or rectal pressure because the baby's right there. So 8 centimeters, and the fact that she's a little bit more irritable and that she's having pretty frequent contractions all suggest that she's in the transition phase of the first stage of labor. Any questions? Okay, question 11. Assessment of a woman in labor reveals that the fetus is in a cephalic presentation and engagement has occurred. So the nurse interprets this finding to indicate that the presenting part is at which station? And again, you are correct. So remember when we refer to the the baby being engaged, it means that the baby's at the level of the ischial spines of the pelvis. And so that's what we refer to as zero station. So if you remember, anything above zero station goes -1, -2, -3. Anything below the ischial spines or zero station is +1, +2, +3. And remember I said +4 means on the floor. So that's a good memory to remember that it's going plus on the way down and going minus on the way up. Good job. Okay. A nurse in a prenatal clinic is caring for a client who asks what her estimated date of delivery will be if her last menstrual period was May 4th, 2015. Which of the following is the appropriate response by the nurse? All right. That is February 11th, 2016. So remember, we calculate this using Nagelli's rule. So if it was May 4th, 2015, we're going to minus 3 months, which brings us into February, right? And then we add 7 days, which brings us to February 11th. So that is indeed the correct answer. Does anyone have any questions about the Nagelli calculation? Nope. Okay, it's pretty easy. Just remember minus 3 months, add 7 days. Good job. Okay. A nurse in a prenatal clinic is reviewing the health record of a client who is 28 weeks gestation. The history includes 1 pregnancy, uh, terminated by elective abortion at 9 weeks, the birth of twins at 36 weeks, and a spontaneous abortion at 15 weeks. So according to the GTPAL system, which of the following describes the client's current status? And you did it again. So we know that she's pregnant currently. So that's one pregnancy. We know that she had a pregnancy that was terminated. So that's two. And the birth, which we count as one, right? Um, and then another spontaneous AB. So we know she's been pregnant 4 times. So that automatically allows us to eliminate B and C. Since we know that she had 2 ABs, we know that the second number is going to be 2. We also know that she had twins, which again counts as one delivery. That's not considered a term delivery. That's a preterm delivery. And assuming both of those twins are healthy, she should have 2 living children. So it's 40122. Everybody did great on that, but are there any questions? I'm really proud. That was probably one of the hardest ones that I would put because we threw in some twins at preterm twins and everything. So great job. Term is 37 weeks and above. For the purposes of this course, you're going to hear different opinions about that, but for the purpose of this course, we're saying 37 weeks and above. What about it? She had what? I'm sorry, Alice. I don't know. Can you put your microphone on? Because I'm not sure what you're asking me.
Uh, what I was asking was for the abortion part, does it matter like how many weeks the patient is, like counting, just like how we're
Yes.
counting above 30? Okay.
Yes, ma'am. So remember we talked about AB is any pregnancy that didn't go to 20 weeks,
Okay.
whether it
Thank
was electively terminated or was a spontaneous miscarriage. So she had
you.
2 ABs.
Thank you.
Good question. You're welcome. Okay, a nurse is performing Leopold's maneuvers on a woman who's in labor, and she determines that the fetus is in a right sacral anterior position. So remember, right, which way we're facing, what the landmark is, which is the sacrum, and it's facing anteriorly. So which of the following presentations should the nurse document in the client's medical record? Is this baby vertex, shoulder, breech, or mentum? All right, so we know that in a vertex presentation, our landmark is the occiput. In a face presentation, our landmark is going to be the mentum, the chin. And in a transverse position, our landmark is going to be the shoulder or the acromion process. So this says right sacrum anterior. So you are absolutely right. This baby is in a breech position. Okay, remember module 2 has a practice activity if you want to practice determining positioning. And so this goes back to that little narrated PowerPoint I did on mechanisms of birth. I think I called it the 4 or 5 P's or something, but I think I called it mechanisms of birth or something. But it's in module 2. Okay. A nurse is explaining the APGAR scoring to a new mother and her partner. What should the nurse point out about this scoring method? And this is going to be a select all that apply. It's done at 1 and 5 minutes after birth. The baby is considered vigorous if the 5-minute score is above 7. Each factor receives a score of 0 or 2. The APGAR score is used to guide newborn resuscitation, or the APGAR score is an immediate assessment of newborn cardiopulmonary adaptation. Which ones do you think apply? We have an A, a B, and an E. B and an E, an A, D, and an E, a B. Okay, we have a lot of different answers, and the winner is Cachet. So we do it at 1 and 5 minutes. And remember, as long as our score is at least 7 at 5 minutes, we're good. If it's below 7, we're still going to do another APGAR score 5 minutes later, and we're going to continue to do that until we have a score of 7, because any baby who scores 7 or above, we're okay with. Now, see, it's kind of a trick question because it said each factor receives a score of 0 or 2, and we know that it's actually 0, 1, or 2. So that was kind of a tricky one. And remember, I said we never use the APGAR score to determine whether or not we would resuscitate a newborn. If we have a baby that comes out and they're not screaming and they're not crying, we're going to definitely start doing interventions versus waiting a full minute before we do that. Now, while we're resuscitating the babies, we're still doing an APGAR score because it, again, still gives us an immediate assessment of newborn cardiopulmonary adaptation. So it's really showing how whether or not our interventions are being effective. And so finally, remember, it's just a tool for an immediate assessment of the newborn cardiopulmonary adaptation. So I've had a couple questions. Would there be a scenario where you might have to calculate the APGAR score? And the answer is yes. Any questions on this one? Okay, let's move on to the next. Question 16. During pregnancy, a woman's cardiovascular system expands to care for the growing fetus. After birth, during the early postpartum period, the woman eliminates the additional fluid volume she's been carrying. What is the one way that she does this? Is it through urinary elimination, elimination of solid waste, being too tired to eat, or breathing off fluid vapor? Oh, you guys jumped on that one, and you are absolutely correct. Urinary elimination. So she's going to have night sweats, and so the loss of fluid is going to be through diuresis and diaphoresis. So sweating and peeing. That's how she's going to get all that fluid out. So remember, their bladders are going to fill up very quickly because they're going to have lots of urine to start to form. So we really want to get into the bathroom every 2 to 4 hours. No, actually, I'm going to say every 2 hours, just so we can avoid having a postpartum hemorrhage due to her bladder being too full. Okay, question 17. A nurse on a postpartum unit is giving discharge instructions to a client whose newborn had a circumcision with the Plastibell technique. Which of the following client statements indicates understanding of the circumcision care? Would she say, I'd expect the plastic ring to fall off by itself within a week? I'd apply petroleum jelly to his penis with diaper changes. I'll wash his penis with warm water and mild soap each day. I'll call his doctor if I see any bleeding. Or E, I'll make sure, well, duh. Sorry, I hit it too soon. So, yeah, so we do expect it to fall off within like 7 to 10 days or so. Because this is a Plastibell versus a Gomco, we don't need to apply petroleum jelly because it's going to be protected by that plastic ring. We want to keep the area nice and clean and dry. Of course, if it came soiled, we'd probably want to wash with some warm water, but very little. We would want them to call the doctor if it was still bleeding. We want the diaper to be pretty loose so it's not irritating. Good job. Any questions on this one? Okay. 18. A nurse is caring for a client who is 3 days postpartum and is attempting to breastfeed. Which of the following findings indicate mastitis? Would it be swelling in both breasts, cracked and bleeding nipples, a red and painful area in one breast, or a white patch on a nipple? Great job, guys. You're absolutely right. So usually it's an area of redness, a painful area. Sometimes it feels warm to the touch. Almost all the times it's going to be accompanied with flu-like symptoms, like they just don't feel good. They're having body aches. They just feel, might even have a fever. They just feel bad. And so that's usually an indication of mastitis when all of this comes together. Now, we want them to immediately call their physician because we want them to be on antibiotics. The worst thing a mom can do is to stop breastfeeding. So remember, this is an infection of the breast. It is not an infection of the breast milk. So we want her to continue breastfeeding, because if she stops, that can lead to milk stasis, and with an infection, that can lead to abscesses. So even if she's saying, I can't breastfeed, have her pump, because otherwise, again, with that infection there, she's going to get an abscess. And again, this way, as long as she gets on antibiotics to empty her breast, she's in good shape. Any question about mastitis? Question 19. A nurse is caring for a newborn immediately following birth. After assuring a patent airway, what is the priority nursing action? Is it to administer vitamin K? Is it to dry the skin? Is it administer eye prophylaxis? Or is it to place the identification band? And the answer is dry the skin, because we know if this baby has a patent airway, we're going to immediately start drying. This is going to prevent cold stress or heat loss through evaporation. But at the same time, just the process of drying will usually stimulate them to cry if they're not crying or breathing at that moment. So no matter what, we dry and we stimulate. Vitamin K and erythromycin are important, but we can usually delay that until after that golden hour we talked about. And then one thing we want to do is put identification bracelets on that, but on the mom, the baby, and whoever mom designates. And the importance of that is doing that before we leave the delivery room, because of course we want to make sure that we have everybody matched up, but we can do that while mom is skin to skin with the baby. Our priority is to make sure that this baby's nice and warm and dry. After breathing, of course. Any questions about that one? Okay. A nurse is preparing to administer Methergin, IM, to a client who experienced a vaginal delivery. The nurse should explain to the client that the purpose of this medication is to prevent which of the following conditions? Is it postpartum infection? Is it hypertension, postpartum hemorrhage, or thromboembolic events? Very good. Postpartum hemorrhage. Now, who would we not want to give Methergin to? What condition could a woman have that would be a contraindication to Methergin? So Methergin is great for postpartum hemorrhage, but we would never want to give it to a woman who's hypertensive, because it's going to cause immediate vasoconstriction and we could stroke the mother out. So Methergin, great medication, but we do not want to give it to a woman who's hypertensive. Okay, so put that in the back of your head. That's an important one. We never give Methergin for women who are hypertensive. So remember your OB hemorrhage medications. That's going to be, of course, your oxytocin, your Methergin, Hemabate, and Cytotec, okay, or misoprostol. Those are going to be those four medications that we tend to give in a hemorrhage. Methergin, we don't want to give it to a woman who's hypertensive. If a mom has asthma, probably don't want to give Hemabate, because it's a beta 2 blockade and it can cause bronchial spasms. But if a mom is hypertensive and has asthma, we're going to give her the Hemabate, because we don't want to give Methergin for hypertensive women, but we would want to give Hemabate even if it causes some bronchial spasms, because dead mom due to hemorrhage or bronchial spasms, we're probably going to go with the bronchial spasm. So again, be very, very mindful that we never give Methergin to a client who has hypertension. So sometimes in a postpartum hemorrhage, you're just running in. You know nothing about the patient, just everybody's coming in. And before you give that medication, make sure you say, is she hypertensive? Does she have a hypertensive disorder? And if she does, you do not want to give Methergin. Okay, any questions about that one? Okay, a nurse is caring for an antepartum client whose laboratory findings indicate a negative rubella titer. Which of the following is the correct interpretation of this data? The client is not experiencing a rubella infection at this time. The client is immune to the rubella virus. The client requires a rubella vaccination at this time, or the client requires a rubella immunization following delivery. Great job, everybody. So when we're testing for rubella, we're testing for the antibody. So if it's rubella negative, that means she's rubella non-immune. Of course, we would never give rubella to somebody who is pregnant or intending to be pregnant because it is a live vaccine. Rubella can cause miscarriage. It can cause birth defects. So if a woman comes in the pregnancy rubella non-immune, we can't do anything at that time, but we would make sure we would offer a rubella immunization after delivery. And again, we would always educate her not to get pregnant in the next 4 weeks because we gave her rubella. Any question about that? Okay, a nurse is caring for a client who's a prima gravida at term, and she's having contractions, but she states she's not really sure if she's in labor or not. Which of the following should the nurse recognize as a sign of true labor? Is it rupture of membranes, changes in the cervix, station of the presenting part, or pattern of contractions? Great job, guys. So definitely if their membranes rupture, we want them to come to the hospital. But just because their membranes rupture doesn't mean they're in labor. We wouldn't send them home because we know that now she's a high risk for an infection because that's our last barrier to infection. But the only way we can differentiate true labor from false labor is progressive cervical change. So it's not based on contractions. They can be contracting every 2 minutes, having pain, but if their cervix is not changing, it's not true labor. I'm just really impressed how well you guys are doing on this. I just have to say that. That just makes me very happy. You're hard workers. A nurse is instructing a woman who is contemplating pregnancy about nutritional needs. To reduce the risk of giving birth to a newborn who has a neural tube defect, which of the following information should the nurse include in the teaching? Is it to limit alcohol consumption, increase intake of iron-rich foods, consume foods fortified with folic acid, or avoid foods containing aspartame? And I already see a bunch of C's, and you are correct. So remember, folic acid is what helps prevent neural tube defects. So it's very, very important that pregnant women take folic acid, and usually they get it in the form of prenatal vitamins. However, if you eat cereals or grains and it says fortified, that's what it means. It means it's also fortified with folic acid. Very hard to get enough folic acid through diet alone, so we really emphasize the importance of taking prenatal vitamins. And ideally, we want the woman to start taking prenatal vitamins as soon as she thinks she wants to try to get pregnant, because the longer you're on it, the better it is. And again, most women don't even know they're pregnant sometimes till 6 or 8 weeks. And most most birth defects will happen in the first 12 weeks. So very, very important they're on folic acid. Usual dose is anywhere from 0.4 to 0.8 milligrams. Okay, question 24. A nurse at a prenatal clinic is caring for a client who's in her first trimester of pregnancy. The client tells the nurse that she's upset because although she and her husband planned this pregnancy, she's been having many doubts and second thoughts about the upcoming changes in her life. Which of the following is an appropriate response by the nurse? Is it ambivalent feelings are quite common for women early in pregnancy? Perhaps you should see a counselor to discuss these feelings further. Have you spoken to your mother about these feelings? And don't worry, your baby will be fine once the baby is born. Beautiful. That is indeed therapeutic communication. So we always want to, this is always my keywords for everybody. You always want to empathize, validate concerns. That's the first thing you want to do. And so we're empathizing and we're validating her concerns by saying ambivalent feelings are quite common. We're not going to say you need to talk to your counselor. We're not going to say, have you spoken to your mother? And we can never reassure them that this is going to go away once the baby's born because we don't know that. So look at you, great therapeutic communicators. I'm proud of you. Okay, question 25. A nurse is teaching a client who is postpartum and has a new prescription for RhoGAM or Rho-D immunoglobulin. Which of the following should be included in the teaching? RhoGAM prevents the formation of Rh antibodies in mothers who are Rh negative. It destroys Rh antibodies in moms who are Rh negative. It destroys Rh antibodies in newborns who are Rh positive, or it prevents the formation of Rh antibodies in newborns who are Rh positive. Very good, everybody. Absolutely. So again, it doesn't impact this pregnancy, but once she has has a Rh positive baby, she's going to develop antibodies. And so with the next pregnancy of an Rh positive baby, her body can actually attack this baby and have miscarriage or something that's called, geez, I'm just totally losing my mind here. Uh, well, basically, it's overall edema of the fetus, and fetalis, something fetalis. I'm totally drawing a blank on this, but anyway, we just want to make sure that Rh negative moms get Rh at 28 weeks, no matter what, and then after delivery, if they have an Rh positive, Rh high drops. That's the word I'm trying to think of. Sorry, if they are Rh negative, they get a dose at 28 weeks. If they had an Rh positive baby, they're going to get another dose postpartum within 72 hours. If they have an Rh negative fetus, we don't have to do anything after delivery. Hydrops fetalis, thank you. Erythroblastus fetalis, thank you. Look at you two, I'm so impressed. A nurse documents assessment changes that occur in the integumentary system with pregnancy. Select all the pregnancy-related integumentary changes. Would it be diastases recti, striae gravidarum, linea nigra, lordosis, or melasma? Which one of these would be integumentary changes? Nice job. So diastis recti would be a muscular skull. Striae gravidarum, which are stretch marks, that's indeed integumentary. Linea nigra, same thing. Lordosis, that's that curvature of the back that can kind of be cause some back pain. So that's muscular skeletal, and melasma, of course, is that mask of pregnancy. Okay, great job. Any questions on this one? Question 27. A woman delivers quickly and a preheated infant warmer is not ready. The infant is placed on a cool surface. The nurse recognizes that the infant will lose heat by which mechanism? The infant is going to lose heat by being placed on a cool surface. And the bees have it. That's going to be heat loss by conduction. So this is why we make sure that we have a warm blanket on the scale. We warm up our stethoscope. We don't put anything cold on the baby. Remember convection, that's the drafts that might be in the room or just having a cold room. Evaporation, of course, is the one when they're wet. So we want to make sure they're drying them because they're losing heat to vapor. And then radiation is that one I told you when they're too close to like a cold area, like an outside wall or a window, that even though it's not open, there's still cold and the baby doesn't have to touch it, but radiation is via heat loss is actually, heat loss via radiation is actually occurring. And that is what I have. Was this helpful at all? Oh, oh, good, 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 good. I'm glad. Okay, that's great. Um, I I'm just really proud of all of you. Like that, you did great on this. This is probably been one of my stronger classes. So I'm very very excited for you. Great job, everyone. And if you have any questions or something came up that, oh, I have a question about that. Please feel free to reach out to me. Everybody should have their blueprint for the exam. If you don't, please give me a call. The exam again will be on Exam Soft. And so the only one I will be proctoring are the traditional students. So you'll have to bring your computer that day and make sure it's set up so that you can have Exam Soft. I will have the exam available for downloading. And then if you're an online student, you'll be proctored at the Echelon Center, so the Simulation Center. And Carol Lamb can help you with any questions regarding that. So, otherwise, you all just stay safe and warm. And again, great job on the review tonight. Very proud of all of you. I'm offering another one tomorrow, but it will be the exact same thing. And you're welcome to join a second time if you want to. I don't know. Some people do. But I will also have it recorded and posted as well. So great job, everyone. Stay safe, and I'll see you soon. My pleasure.
I do have a quick question.
Sorry, are you able to hear me? Hello?
Yes, sorry.
Oh,
So
good.
just to
No, I
confirm, we
just logged off and I heard it and then I'm like, oh, come back, come back.
do.
Yes,
Yeah,
ma'am.
sorry. So we do want
No.
the mom to be ROGAM positive, correct? Or not
So
ROGAM
not
positive,
Rogan.
but RH positive?
Well, we don't have to do anything if mom's RH positive.
Okay.
So just if she's RH positive, it doesn't matter what blood type the baby is. It's only if she's RH negative. And the reason we give her RhoGAM at 28 weeks is that some women could potentially have miscarried in the past and not even been aware of it. So we don't know if she's had any exposure. So we just automatically give it to all Rh negative moms at 28 weeks. And then if she has an Rh positive baby, we'll give her a second dose within 72 hours after birth. But if it's an Rh negative baby, we don't have to do anything.
Okay. Okay, thank you. That's the only thing I was confused about. So thank you for clearing
Please
that
to
up.
be confused with that one. It's then no problem. That one can be confusing. So you're not the first.
Okay. Thank you so much for
Okay.
reviewing. Thank you.
Oh, you're so welcome. Thanks for coming.
Okay, I'll see
Bye
you.
bye.
Bye.
See ya. Bye bye.